I'd like to thank the organizers of the WAGR weekend for this very nice invitation. I really appreciate it. And I'd also like to welcome all the participants from all over the world. My name is Peter Netland. I'm at the University of Virginia, and I'll be talking about aniridia and glaucoma. So glaucoma is a potentially vision-threatening problem. This is a cause of irreversible vision loss. It's common in aniridia, and any age can be affected. Oftentimes this occurs in childhood in aniridic patients. The treatments for glaucoma are effective, so it's very important to try to identify this disease while it's asymptomatic, this problem, so that it can be treated before any vision loss occurs. So there's various causes of aniridic glaucoma in terms of the mechanisms. In newborns, infantile glaucoma is fairly uncommon in aniridia. It's usually due to some sort of coexisting anatomical problem in the drainage part of the eye. But more commonly, this occurs a little later in childhood and early adulthood. The most common form is an open angle glaucoma. Angle closure has been described, especially after other surgeries, and a progressive angle closure, chronic progressive angle closure has also been described, but this is probably relatively uncommon. We did look at the mechanisms in some detail in a comparative study to determine if patients with aniridia and glaucoma had open angles on OCT and gonioscopy. We looked at 86 eyes, and in these eyes, 27 patients had been diagnosed with glaucoma and 16 patients had no evidence of glaucoma. In this group, aniridia was the most common diagnosis with familial and 20 patients and sporadic and 23. We had no WAGR patients in this particular study. The findings are shown here. The majority of patients had open angles, 50 of 54 eyes, 93%. We did have 7% of eyes, that's 4 eyes, that had angle closure with glaucoma. In these eyes that had closed angles, all of them had had prior surgery for cataract glaucoma and or keratopathy. So we felt that the prior surgery was probably a factor in developing glaucoma in these patients that had this type of secondary glaucoma, secondary angle closure. So we reasoned that this is probably because aniridia is a profibrotic syndrome, and there could be scarring after surgery that may lead to angle closure in a small proportion of patients. So this is a typical kind of finding that we saw in the study. We had, this is an anterior segment OCT image here, and you can see in this patient on the left, upper left, there's a nice open angle there. You can visualize very well. This is the iris stump, and you can see that angle really nicely with the OCT. This is a patient that had a closed angle, one of the 4, and this is the iris here stuck onto the cornea and is covering up that drainage part of the eye, the trabecular meshwork area. This is just a photograph of an eye with aniridia and glaucoma with a relatively clear peripheral cornea here that we could do gonioscopy on in this patient, and we were able to find out this patient had an open angle on gonioscopy and had coexisting glaucoma. So glaucoma and aniridia and WAGR is thought to be fairly prevalent, but in the literature there's a fairly wide range of prevalence rates that are reported, from 6 up to 75%. Probably the truth is somewhere in the middle there. WAGR, there's a nice study about WAGR patients by Kelly Trout, our own Kelly Trout, and her co-workers that was published in 2005. They looked at 54 subjects and found glaucoma in 24. That's a 44% prevalence rate. The median age in their study was 9.2 years. And another study shown here is one that I'm a little bit biased about, but it's one of my favorites. It's one that we wrote a couple of years ago, I think 2011, in a series of patients with aniridia. Only 2% had WAGR. Glaucoma was found in 38 of 83 subjects. That was 46%. The median age in this group was 19.8 years, which is a little bit older than the WAGR study, which could have contributed to the slightly higher number because age is a risk factor for increasing prevalence in this study. So probably in the range, what I like to say to patients is about half the patients with Aniridia will develop glaucoma at some point, and whether or not this is different in Aniridia and WAGR is unclear. Obviously, they seem to be pretty similar numbers. It could be that they are similar, but there's been no comparative study. It would make sense in some ways if there was a slightly higher prevalence in WAGR, but this doesn't seem obvious from these numbers, and there's no comparisons in the literature to help us know if it's more common or not than it is in just straight Aniridia. So the glaucoma is fairly common. In our series, we had about a 46% rate of glaucoma in these patients. The age of diagnosis, the mean was 13.6 years, and the median was 8.5 years. So approximately about half the patients were diagnosed with Aniridia with glaucoma by 8.5 years of age of those patients who developed glaucoma. Most of the patients that have glaucoma require treatment with medications, and a majority of patients also eventually require some sort of glaucoma surgery. Clinically, we measure the pressure in these patients. It's very important to us to try to help us understand if the patients have developed or are developing glaucoma. Usually the patients have they inevitably have an increase in intraocular pressure. The gold standard for this is applanation tonometry, but we've found rebound tonometry to be very useful as well. This doesn't require an anesthetic and can be used in young children without having an anesthetic, and so it's quite useful to us. The results of any of these types of measurements can be influenced by corneal thickness, and the corneal thickness is increased in Aniridia. That's quite well documented. So we do try to take that into account when we're interpreting these measurements to help us understand if the pressure really is elevated or just sort of a high normal. Nowadays in the office, a complete examination is often possible without anesthesia. We do find the rebound tonometer to be very useful to try to complete as much of our exam in the clinic as possible nowadays. It is impractical to use a sedative now. We used to use that quite commonly, some sort of sedative, but now the rebound tonometer would need that less frequently. Occasionally, though, it is difficult to get all the information that is needed, so we do sometimes do examinations under anesthesia if the patient isn't able to tolerate the exam in the clinic. But this is now, pretty uncommon with the improvements in some of the diagnostic testing. We recommend examinations about every 6 months for individuals that haven't developed glaucoma, and this frequency may increase if the patient develops glaucoma. Certainly glaucoma can develop after an initial examination which doesn't find any evidence of glaucoma because age is a risk factor. As everybody gets older, they're more likely to have an increased chance of developing glaucoma at some point. So the treatment for Aniridia is effective. Medical treatments can oftentimes be used. Laser isn't very useful. And then sometimes we have to treat patients with incisional surgery for those that don't respond well to medical treatment. Surgery for Aniridic glaucoma varies. Many clinicians use goniotomy or trabeculotomy. These can be effective, but the longer term success is not as good as it is in patients without Aniridia, such as maybe congenital glaucoma patients. Perhaps this is due to the profibrotic syndrome aspect of Aniridia, but a bit more effective is the trabeculotomy and trabeculectomy combination, or a trabeculectomy with mitomycin C. These are transscleral filtration surgeries that can be used. Most frequently, though, we're probably using glaucoma drainage implants. Occasionally cyclodestructive procedures are used, especially as some sort of adjunctive treatment for drainage implants, and then other procedures can be used as well. Drainage implants are oftentimes used for patients that do develop elevated pressure, intraocular pressure, that's refractory to medical and surgical therapy. We use them because there may be some limbal scarring and failure of conventional surgery like a trabeculectomy or other transscleral filtration surgeries. Failure rate can be a little bit increased. So we'll use the drainage implants as a way to have a higher efficacy with our surgery in this situation. We're really interested these days in some of the new developments in glaucoma surgery, minimally invasive glaucoma surgeries, so-called MEGs, are being developed. There's a lot of interest. We use them frequently now in adults, and there's less information about these procedures in children. They are safe. Initially, they weren't quite as effective as drainage implants or trabeculectomy, but this is improving with modifications of these minimally invasive surgeries. And we do have only anecdotal experience in Aniridia, but it does appear to be beneficial in some patients. So this is a developing area that we're very, very interested in, and we feel it may provide a way to control the pressures with less invasive treatments. A few examples of those are shown below in some of the treatments that have been used in Aniridia patients, and these are all very promising, but we do have to collect more information about this before we can recommend this approach more broadly. So in conclusion then, Aniridia is often associated with glaucoma, causing progressive vision loss. Patients oftentimes require surgical treatments which generally have good outcomes. Monitoring and prompt treatment may prevent vision loss due to glaucoma and Aniridia, and the new surgical and medical treatments are very promising indeed. So I'd like to thank very much IWSA for pulling together this great conference. I'd also like to thank Aniridia North America, NA, Aniridic Family Vision for Tomorrow, Aniridia and Aniridia Europe as well, and they're having their meeting coming up soon. I especially want to thank the patients that I'm following, their families, and my collaborators in all of this work, who I am very, very appreciative for and very appreciative to. So thank you all very much for listening in, and I hope the rest of your weekend is informative, productive, and enjoyable. Thank you all very much.